Okay. So if everyone is happy to let others into the meeting, that would be amazing. Just because obviously I still can't see. I don't know how to make presenter mode on this thing, but we'll figure it out one day. So this case is an interesting one. I'd love to have as many people's thoughts as possible, specifically more to do with the antenatal CTG, and I think that's the sort of key message I wanted to sort of get across in this case review. So, maternal history: she is a gravid of 5, para-naught. She's had 2 previous miscarriages and 2 terminations of pregnancy, all of which were at early gestation, less than 12 weeks. BMI of 29, age 25, low risk pregnancy at booking, but multiple fibroids were identified at her nuchal scan. She was 36 at her 36-week scan. Baby was cephalic, placenta posterior high, normal fetal growth in Dopplers. And I think the baby at this point was on something like the 60th, 70th centile. Those are all the sizes of her fibroids. So these weren't just little ones here. They varied from being anterior, high, fundal, and the lowest one was low posterior, but none of which were in the way of the os. She came into triage for a couple of episodes of abdominal pain across 2 days. She had 1 episode of reduced movements at 30 weeks. She was query Schrom at 40 weeks, but it wasn't Schrom. And then at 40+3, she came in for a 2nd episode of reduced movements. So an induction of labour was offered and accepted. So this was her admission. Sorry. So she came in. Dawes-Redman criteria met in this CTG at 40 minutes, but just due to the ward activity, this was a specifically busy few days. The team decided they couldn't start her induction just purely because they didn't really have the capacity at this point in time. So she was admitted to antenatal ward for some monitoring prior to them commencing her induction. So we all happy with this? Did I mention, sorry, she's 40+3 at this point.
Baseline's a bit high for gestation, I think, but otherwise.
Yeah, I thought the same thing. Although stable, good accelerations present, good variability, no decelerations. So we would be happy to sort of continue with this, but yeah, we know that the baseline's starting higher, so just something to be aware of. So on the 13th, her CTG was commenced at 02:10. She was immediately turned to left lateral, as I'm sure you can imagine why. And at 02:20, she was examined and her VE showed that she was os closed. And what was written in the documentation was variable decelerations were noted. So if we're moving to a sort of physiological approach, technically variable decelerations would be classified as sort of baroreceptors. But yeah, what are our thoughts here? Are we going to want to start an induction on this?
No, she's contracting, the baby's showing you signs of distress, and if you put it on straight away and you've got sort of a prolonged deceleration, you're wondering why.
Yeah, I definitely agree. I know that we're moving to a more physiological approach, but I would sort of declare these sort of decelerations that they're late, they're happening after the contraction. We're not really sure what's going on at the beginning of the CTG here, but baseline still remains the same, but that just shows us an even clearer indication that these decelerations are in fact decelerations, quite shallow, but they wouldn't necessarily be a cause of sort of head compression because they don't sort of coincide with the contraction. So we're sort of wondering here, okay, what is this baby up to? We're probably not going to start an induction, specifically also considering the fact that we've actually had what looks like maybe 5 to sort of 10 minutes of a baby decelerating before returning specifically back to the baseline. So the CTG continues. The client's feeling very uncomfortable, wants to get up and get moving, and would like a break from the CTG. The midwife has very clearly documented that she's recommended against this, but this woman was uncomfortable, and so she was taken off the monitor. And induction of labour was not started. Anybody want a registrar review at this point?
Yeah, I do. She's contracting more regularly and showing sort of loss of contact here, which potentially could be D cells. You also have to think about, is this baby fit for labour?
Yeah.
Which right now I wouldn't be keen on letting her off the CTG. So then I've got to think about, what's my plan? I want a registrar review, potentially transferred to labour ward, or delivery suite, and potentially what is my long-term plan as well? Like, where am I seeing this going? I
Yeah.
wouldn't start to toe on this. I wouldn't want to ARM this. What is our plan? So it's the long-term plan rather than right now. It could
Yeah.
be an absolutely normal CTG, but what is the long-term plan? I think that's what we've got to be thinking of as well.
Yeah, absolutely. So like I said, the night was very busy. Obviously, we've got to consider our human factors here. I'm not sure, it's not very clear whether or not a registrar ever came to review this CTG or whether it was taken to a registrar because it's not documented. But that's always a possibility. But yeah, the induction of labour wasn't started. So we're happy that we're all on the same sort of plan here. Just moving forwards, would have been good to have had that review to sort of determine what we are going to do next with this lady. So we'll continue. So that one was at 2 to sort of 3:30 in the morning. This woman's agreed to go back on the CTG at around 4:10 in the morning. And this is your CTG now. Thoughts?
So an abnormal CTG.
Go on, Petronella, what were you going to say?
The abnormal antenatal CTG. She's not in labour yet.
Yeah, absolutely agree with you there. Unfortunately, this wasn't escalated. Okay, so going back to our sort of guideline, if you like, when we're in labour, we tend to be on sort of labour ward or birth centre. We've kind of got that reassurance that we do have the doctors around and whatnot on Hope Ward. That's obviously not the case at all times. But this CTG was actually considered normal and accelerative.
I think we've got to go back to the human factors here. Just we've all worked on Hope Ward and we know what it's like where you put someone on the CTG, which from the get-go here, I would have put her on and walked away. We're not watching this straight away. So because I put her on and walked away, when am I taking her off? And potentially, I'm not saying it is an abnormal one, saying CTG, we agree on that, but I'm just thinking the human factors element, we've got to look at the system issue. So we've put her on and we've walked away. So we're then looking back on hindsight again from an antenatal point of view. What would we be thinking if we were on the antenatal? We're not going to take her off, but we're thinking what exactly? And I think that's the biggest part of this in the human factors element, rather than looking at this as if we're on delivery suite. Does that make sense?
Yeah, absolutely. It's a tricky one. Obviously, like I've said, the ward activity was very high. Personally, if we all know what Hope Ward is like, but yeah, if we would have put this woman on a CTG, we definitely would have walked away from it at some point and not necessarily paid very close attention to it. However, if I continue it even further, it does normalise. It does appear to be sort of more. I would definitely say that this sort of segment of the CTG was very much different to the one previously, but it's what's documented afterwards that I had some slight concerns with, in the fact that this has been classified as a normal CTG. We're reporting these 2 variable decels, and the word variable is not one that I'm particularly fond of, just purely because every single deceleration varies in height, length, and strength and whatnot. Sorry, not decelerations in strength, but you know what I mean? So you could argue that the wording is right. However, this is what I would consider a chemoreceptor deceleration here. And any decelerations when we're in the antenatal period is classified as abnormal, so does require escalation. But it's the fact that this is classified as the CTG is classified as normal that's kind of my concerning feature. Other than those decelerations, however, we've clearly got here quite a nice stable baseline, accelerative, good variability. So if it was just this part of the trace, yeah, we'd go with normal. But considering what we've had before, slightly more tricky. Anyway, The CTG is discontinued at the end of this at 5:20 in the morning. So also a human factor here is the fact that our midwives are probably quite tired at this point, who is used to being up at sort of 5 a.m. in the morning. And we don't know what was going on necessarily on with the other women on Hope Ward at that point in time. So we'll continue. Who was somebody going to say something?
I was, but ignore me. We covered it.
Okay, cool. So at 11:50, the registrar has now done the ward round on Hope Ward and has noted the fact that the CTGs overnight were abnormal. However, reports that they obviously resolved back to a normal trace. The plan was put in to redo the CTG this morning. If normal, then insert the ProPES and then continue regular monitoring thereafter. I'm just thinking you probably can't see the obs on here either. So yeah, 11:50 IV access was obtained. And at 11:57, ProPES was inserted, and at this point, OS was closed. Blood pressure 104/69 with a pulse of 100, temperature of 36.5 as well. I think the pulse being raised was slightly down to maternal discomfort, but it wasn't repeated following. Happy to put a ProPES in here?
No, I'm not. I want to not stress her, not stress the fetus.
Does anybody else want to comment?
I think we have to do one or two things. I mean, the plan was to induce, so we need to, I would say transfer to labour ward and induce there.
Yeah, I thought the same thing, Petronella.
For closer monitoring.
Yeah. Obviously, ward activity is high. I think it had settled down by this particular morning. So I think they had 4 women on labour ward at this point, and the night had been busy, but we'd managed to sort of work our way through everything. But yeah, I would have sort of said the exact same thing in view of the fact that the CTGs were abnormal overnight. I think closer monitoring would have been slightly better. The benefit of our sort of central monitoring system would sort of play here. Just so we've got an additional pair of eyes on the CTG. Whilst we only have sort of fresh eyes and whatnot for women that are labouring, it's also something to consider. A lot of trusts, not Croydon, but a lot of trusts, all of their antenatal CTGs need to be countersigned by an additional midwife. So that was something that I thought about in terms of our guideline. For sort of antenatal period. I appreciate that that's going to be a bit difficult if you're working lone in triage and whatnot, but just something to be considered. But we have induced on Hope Ward. So this is our post ProPES CTG. And I would argue that this baby looks reasonably happy here. Baseline sort of sat at 140. We've got nice accelerations, good variability, and no decels at this point. Yeah, everybody in agreement?
Yes.
Yeah.
Perfect. Later on in the evening, this is your CTG. So this is at 6 p.m. ProPES was put in at 11:57. Anyone saying normal?
No. I think the baseline's wandering now.
Yep. So you need at least sort of 2 to 3 minutes of CTG to determine the baseline. So looking at this in between sort of 18:10 and 18:20, we do probably get about 3 minutes of a baseline of 150. She didn't have the clicker, so obviously difficult to determine whether or not these are sort of accelerations and whatnot from movements, but you could argue that actually there's another period of time sort of at the 18:20 mark where this baby spends 3 minutes or 2-3 minutes at the baseline of 160, which would mean the decelerations. again, unfortunately, no escalation was made to any of our registrars or to anybody else or any other midwife in the unit at the time.
For me, Cara here, it doesn't, doesn't have any doubts that it is acceleration or deceleration. It is obviously it's chemoreceptor deceleration. There is, I don't know, I can't see a doubt about it.
Yeah, no, I don't disagree with you at all, Naguib. I think based on what we've already seen that this fetus has been telling us since before we've even remotely induced labour, just with a few tightenings, she was sort of tightening before, maybe 1 in 10, 2 in 10 on some occasions. I don't think she was feeling them either, because no pain relief was recorded. Not obviously everybody needs pain relief, but there was no documentation really as to her discomfort, other than the fact that the CTG was annoying her previously, in one of those traces. But yeah, here, difficult. It continues as well. So I think this makes it a little bit clearer for everybody. So we're now at a full almost hour's worth of CTG trace with a baseline of 160 and chemoreceptor decelerations down to sort of 120, 130 at times. So I think this makes it even more clear that this baby is very much struggling. However, in the documentation, this CTG is reported as being normal and accelerative.
Sorry, Cara, is the ProPES still in?
Yep. Yep, ProPES is still in. CTG is considered normal. I've put all of the observations that were taken throughout the entire period of time that this woman was admitted to delivery on the monitor, on the slides. So I do believe that the midwife that was taking this CTG did genuinely think that this was a normal trace, and that possibly there was consideration that the baseline was sort of sat at 140, 150, and that these were actually accelerations. Movements weren't reported in the documentation either. So if we are caring for women, obviously, again, we know that we're on hope ward. We know that we're not going to be watching this all the time. But if we've got a lady on the monitor and you're writing that sort of accelerative, we can argue that, yes, you can say that that's just down to fetal movements, but without sort of documenting it, it just makes the case even less likely. So yeah, at this point, I'd definitely remove the ProPES. I would definitely be calling labour ward, either transferring or asking for a registrar to come and review the trace on hope, and really escalating the concerns that we think this fetus is struggling.
For me, Cara, as well, and this is, a lesson to all of us. If I'm seeing this trace, sometimes I don't understand why should we transfer first to labor ward and then to theater. I would counsel her in hope about C-section and go from hope to theater. Personally, I don't know why we should get her to labor ward first as a transition. The transition doesn't make sense to me. The baby has been telling me I'm chemoreceptor for the last 2 hours or more. So if we agree that we need to go, as Petronella said, one way or another, either induction or either delivery, and I think it has shown it needs delivery, then delivery. Why do we need to go to labor ward then to theater?
Absolutely. I think that's a very much an alternative approach. It doesn't really happen very often on the unit, does it? So, but it's definitely worth sort of considering. And if this was picked up as being, quite significantly abnormal, then that almost certainly could have been the case. However, the CTG in this instance was discontinued. So bearing in mind that we've had a initial baseline of 150, it settled when it was looking slightly more normal down to 140, and we've now got a baseline of 160. We're going to be keeping a slightly closer eye on this CTG. Well, we should be on continuous monitoring. However, that wasn't the case in this instance. So I'll move on. So at 23:55 on that same day, the PROPES fell out, and the woman came to report it to the midwife. At 00:10, she was reported to be contracting 4 in 10. And at 00:20, the examination found her to be 4 centimetres dilated, 2 centimetres long with bulging membranes. This was the result of the CTG after, as you can see, after the examination. And then it continued for a while, just while the midwife was recommending transfer to labour ward. And then at 0100, we transferred. Baseline appears to have sort of settled down, but it's very much wandering, which can sort of, if we're going from 160 to 140, from 160 to 140 again, and then coming down again, sometimes there's some research that supports that this is actually central nervous system instability when you've got a slightly wandering baseline. So we've moved to labour ward. This is your CTG now. 01:15, she's moved to left lateral. She's cannulated and bloods have been taken, group and screen and FBC, I believe. And her observations on all of the slides are put in the box where they were taken. So this was about, I don't know, 01:35 or so. Blood pressure normal, pulse normal, temperature 36.4. So we know that it's not a maternal concern that's causing this fetus to become distressed. So this is our baby still telling us that I'm sick, I'm not very well. Anyone want to move to theatre?
Yes.
Who was that?
Anais.
What would you like to do, Anais?
Go to theatre.
Why?
Because the CTG is abnormal.
Yeah, she's 4 centimetres though, so she's technically in labour now. What would you classify it as?
Still abnormal.
Pathological.
Pathological?
Yeah.
Anyone agree or disagree?
I agree. But I'd like to give
Agree.
as well. The butylene, Cara.
Yeah. Perfect. So we'll continue with the CTG. So as requested, registrar review was at 01:40. And the VE was and repeated the examination just to clarify, and the registrar found her to also be 4 centimetres dilated, and at 01:48 terbutaline was given. It was at this point that the obstetric team reviewed the previous CTGs and noted that an abnormal CTG on 3 occasions wasn't escalated to anybody from the previous night shift and to the day shift. The registrar that was in the morning review didn't see the following CTGs in the daytime. So yeah, very much erring on the side of caution with this baby now. And at 0200, the CTG was shown to the obstetric consultant on call, and was reported to be a suspicious trace. I think this was following the fact that we'd given terbutaline. I'll continue.
Mm-hmm.
So 0220, CTG reported on fresh eyes as being suspicious, but the plan at this point was to continue to observe. We still have the theatre opinion, or are we happier now?
Theatre.
Yeah, anybody else?
Happier now?
Happier now?
I am.
Yeah. Yeah, I know, I do agree with you.
I can see more baroreceptor like decelerations now that she's on the labor ward with a stable baseline of 140. It's accelerative. I'm happier now.
Cool. So yeah, I think I would agree with you now. We're obviously not going to do anything remotely to this baby. So if these contractions, if this CTG gets significantly deteriorates, then I think go to theatre. I think pre-meds on standby at this point. For sure. Also maybe an FSC, just because we are getting some loss of contact, and it does happen to coincide with where it looks like decelerations, although the majority of the trace is completely is completely adequate when it comes to the quality of it. I would personally, if in this situation, considering the entire clinical picture here, put an FSC on just to sort of better determine that we are picking up the right thing at all times, basically.
I think she still has 4 waters, Cara, as far as I know.
Yeah. So there's no SHROM or anything. Anyone want to do that magical trick where we ARM and the CTG gets better? I don't know who's giggling at me, but whoever it is knows exactly what I'm talking about. We'll continue. So O243, the woman is becoming more distressed. So an epidural is offered but declined, and she's using Entonox effectively at this point. So O245, blood pressure is 124/81, pulse is 100 again, and temperature 36.5. I think it's been made quite clear in the documentation that the pulse being slightly raised, considering the previous one was 80 with not as many contractions, is that the pulse is sort of pain related. So when we are taking maternal pulse, just to make sure that we're doing so after the contraction is over and in the spaces in between. The plan at this point by the obstetric registrar was to continue to monitor the CTG. Anyone want to change?
She's a primate, but we don't want to ARM because we've got CTG concern. We can't start Cinto because we're CTG concern. What are we observing for?
So something that I found very interesting is that none of the obstetric reviews on this CTG that's documented by the midwife were ever documented by the obstetric registrar.
Yes.
So very difficult to sort of have the rationale behind it. But yeah, I don't know if we've got any obstetricians on the call. I know Mr. Naguib is there and is very, very much documentation. But yeah, just to sort of reiterate that if you are midwives, if you are having a registrar review on a good few occasions, just make sure that you are documenting what the plan is, but also asking them to do so as well, or even just to sign the CTG, just to sort of say that they're happy. This is really, really important. Okay.
And I agree with Anais. The problem now is, what are we observing for? If it was me, I would do one of two. Again, either I deliver, or now that the CTG is slightly better, I ARM. I finish the story. It is like becoming more painful now.
Yeah.
Yeah.
Perfect. Continuing. At 03:35, an ARM was not necessary because she's SHROM and clear LICOR was seen. So now that we've kind of got that factor in place, The plan was again to just sort of continue with the CTG monitoring. Hopefully that the fact that she's SHROM will hopefully make this lady progress to a point where she eventually will get to sort of fully dilated, I think. We'll continue. 0345, fresh eyes with the second midwife was noted to be suspicious. Are we in agreement? Well, 0357, she went out to the toilet past 100 mils. That's the first time that she's been out to the toilet as well since she came to labour ward earlier on in the evening. Just to make sure, guys, this is just a sort of side note, but just making sure that we are making sure, sorry, no need to say that so many times, that we're looking after our women's bladders during the labour process, because we know it has an impact on progression, but also making sure that they're staying nice and hydrated as well and keeping that fluid balance chart. She comes back from the toilet. Baby clearly did not like being taken off the CTG, and they turned her to left lateral immediately after starting it. And you can see these sort of chemoreceptor decelerations are starting to come back again now. We'll continue. Anyone want to share their thoughts? No? Okay. We'll continue. Move to right lateral at 0444. Just because she wanted to be more comfortable. CTG continues. It continues like this for a little while. But I would still say that we're still getting these chemoreceptor decelerations. We've got good variability within them, which is a really reassuring sign that baby's still sort of compensating. But we're still getting them. And we're now, 2 days-ish post the first chemoreceptor deceleration. So it just sort of makes you think how baby's going to be born in the end, and what kind of condition baby's going to be at, not just for the short term, but for the long term as well. So we'll continue at 0535. She's found to be 6 centimeters dilated, and more SHROM comes clear liquor at this examination. At 0537, so just at the very end of this trace here on this slide, she's turned to left lateral again. And an emergency bell is pulled because the deceleration drops down and doesn't show any sort of signs of recovery here. Apologies, I should have tried to put this all on so you could see the whole thing on the one slide, but as you can see, we kind of go down at about 0538, 0537, it continues. And it doesn't really recover properly for about 10 minutes here. Registrar comes in to review at 0544 and finds the cervix to be 5 centimeters dilated. And at 0547, Terbutaline is given. I know we always go on about our sort of 3, 6, 9, 12 rule. We tried the conservative measures. We moved her position and we gave Terbutaline to see if it recovered, and it did. But this is quite a significant amount of time for a baby to be in a deceleration. The reassuring factor being that the variability is good within the decel from the sort of contact that we are picking up. But something that I've sort of picked up doing some of the additional study days is that if the CTG is normal before we get sort of an acute situation, there's like an 80% likelihood that the baseline and the CTG will recover back to baseline. However, if abnormal before, the chances of it doing that is very, very, very much small. I think it's less than 30%. And as you can see, we go back up to the baseline and then baby goes straight back down again. So this baby's really telling us I'm not very well. I'm becoming significantly more sort of hypoxic now. There's no sort of symptoms of choreo within mother or baby. Does anybody want to try and sort of define the hypoxia here?
I'm going to say subacute because of that prolonged deceleration, and then after that, there's reduced variability with some baroreceptor decelerations after. It looks, well, I would say gradually evolving because of that prolonged deceleration. If I go further than that, then I can say gradually evolving.
Yeah, I think I would agree with you with the gradually evolving, although I don't know if I would agree with you in saying that these were baroreceptors, just purely because, yeah, I would personally, I'd consider them more chemoreceptor decelerations, just because the variability on the way sort of down to that to the peak of the decel is very, very, very much pencil tip, and it is much slower to recover than we would like it to be, whereas our barrows do tend to be slightly more short, sharp, quite quick to recover, whereas the further this sort of CTG does go along, I'd say it takes longer. But Mr. Naguib, I don't know whether you want to sort of weigh in here.
I agree that they are chemo. Yeah.
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 Okay, Mr. Naguib, what do you want to do? Would you want to move to theatre now?
I think I wanted to move to theater 3 hours ago, so the baby now is delivered with the mother in my head.
I think everybody on this call, I think there's quite a few people that would be thinking the same thing. If anybody does want to sort of comment in the chat and doesn't want to speak out loud, please do say so, but someone else is going to have to read it out for me, because I can't see it at all. Okay, we still continue, however, but bear in mind we're now at 6 o'clock in the morning. Think of our human factors. Who wants to go to theatre at this point? At 6:21, pre-meds were given in preparation for theatre. And we continue.
Luke, are we by ourselves?
What's that, sorry? Did somebody want to comment? Sorry. No? Okay. The only reassuring thing that we've still got going on, which I think is really important to mention, is that our variability has remained very, very good throughout the entire sort of CTG so far. So the baby's still compensating. But how long do we need to leave this before the baby says to us, okay, I'm done now, I've completely given up, and then that variability sort of completely tails off? This may have been one of the situations where we benefit from Stan, but looking at the overall clinical picture, we've now had a baby that's showing us signs of distress since almost 2 days. And yet there's still not been any significant documented plan as to how we're going to resolve this.
Cara, someone's raised.
You're gonna have to shout at me because I can't see any hands raised, I'm afraid.
Hi, Cara. I just wanted to ask if there was any fresh eyes.
Yeah, so the fresh eyes were reported a bit earlier on in this sort of segment of the trace, Catherine. Not as there wasn't any sort of documented, but all of the previous fresh eyes sort of reported it as suspicious. But now now there wasn't any fresh eyes documented. But also this is one of the reasons we also want to move to the physiological approach away from FIGO, because it's all very much well and good us turning around and saying this is a normal CTG, this is a suspicious CTG, this is a pathological CTG. But when we use the FIGO as a form of assessing this CTG, we're not really doing anything about it. Whereas if we can sort of better define things like a gradually evolving hypoxia, it kind of makes it, I would argue that it makes it easier to then determine the plan going forwards. So what would we do with the gradually evolving hypoxia? Instead of just calling it suspicious and leaving it at that over a continued sort of period of time. But we'll continue. At 06:41, so right at the beginning of the CTG here, this woman has opted for an epidural. Her blood pressure is stable with a pulse of 103 still. 07:03, registrar comes in for a review, and fluids are increased. Blood pressure now of 127/79 and a pulse of 101. And I think this baby now, I think we are definitely on track when we say gradually evolving hypoxia, because as the CTG's gone on, our decelerations are now getting longer and deeper and taking much longer to recover. And we're still having chemoreceptor decelerations at this point. This baby's been telling us for a while that we're struggling. Also, if you look at the previous CTG here, and you think back to the beginning where our baseline was sort of sat at 150, then at slightly better CTG quality, the baseline was 140. I would almost argue that actually a lot more of this is within a deceleration than we may think looking at it. Does anybody want to comment on that?
No, I wanted to ask, how many centimeter are we now again? I missed that.
5.
Okay. So 5 and the previous one was 4?
Previous one was 6 by the midwife, but the registrar identified it as being 5. But the previous one before that was 4, yeah.
So let's say that the trajectory from 4 to 5 now, we are on how many hours?
So her first VE was, I think, at 10 past midnight, and she was 4. So we're now 7 hours later and remain the same, and have moved a centimeter.
Right, and this wasn't considered even if we don't consider the CTG, we are not considering the progress.
Like I said, Naguib, none of the obstetric reviews were documented.
Okay.
So the whole course of the night, not a single registrar documentation is on Cerner that I could see. Considering it's now been 7 hours and we've made a centimetre's worth of progress, we can't start Synto because we've got a suspicious CTG. We've already wanted to go to theatre about 4 hours ago now. There's nothing that we can do to help this woman progress due to the factors that are already there. We're going to be heading in that direction. I don't know whether the decision was made to sort of delay until the day shift, but there's no, I can't find any documentation for it. That's again when our overall clinical picture comes into account. But we'll continue. We've got a nice baseline rise now. So this baby is releasing those catecholamines and saying, oh, my heart needs to work harder, so it's going to have to work faster now to get me what I need. She's moved to left lateral at 10 past 7, so just at the beginning of the CTG. And then and the temperature's gone up to sort of 37.4. It's been sat at 36.5 the whole time. Based on the baseline rise, the decision was made to give IV paracetamol. We'll continue because I know we're getting very close to the end now. The IV paracetamol appears to have sort of brought the baseline down. Blood pressure remains stable. Mum's pulse has come back down again as well. And our second bag of Hartmann's has started at 07:46. I'm just trying to think when she would next be due for an examination. So 05:44, she was reported to be 5 centimeters. So 9:44 would be the next examination, if not done so beforehand. We'll continue. Looks like it's kind of normalizing again. But based again off our overall clinical picture, we've been doing this back and forth for quite a long period of time now, and no plan's been put in place. Our day shift team have taken over between sort of 8 and 8:30. The first set of obs that were done, pulse is 97, temperatures sort of come back down from that 37.4. Still getting some chemoreceptor decelerations, I would argue here, based off of the fact that I would say our baseline is now looking at about 150. And they are sort of coinciding with after the peak of the contraction, so late. We just keep going and keep going and keep going. Baseline appears to be sort of settling down to 140 now. But also think of the length of these contractions. This Toko's picking her contractions up beautifully. And if you think something that was mentioned again at one of the sort of master classes, it's not about how many contractions that you have, it's about the sort of resting time in between. These contractions are probably lasting over sort of 3 minutes, and yet she's only getting a minute or two's worth of rest in between. So not only is this fetus tired, but mum's body is also going to be getting more and more tired now as well. Day reg comes in at 09:55, says that this lady remains 5 centimeters dilated with a presenting part at -1. And as you can see, the baby did not particularly like being examined. We'd much prefer it if it was much more accelerative during the examination. It looks like possibly baby did respond to it, but then afterwards responded with quite a significant sort of 3-minute long deceleration. We just keep going.
Sorry, Cara, can I ask, when the day reg came in and examined, was there a plan, or the plan was just to like watch and wait as we have been doing?
Watch and wait.
Even though now, like, she was 4 centimeters at midnight, and then now at 10 a.m. she's not really progressed, and her CTG is not great. Okay.
Yeah, I think from what I can kind of decipher from the documentation, I think this registrar was going to complete the ward round before making any decisions as to what was going to happen, who was going to go to theatre first and whatnot. But it's not clearly documented anywhere. And this wasn't one of the nights that Cerner went down either, so it's not like that's the sort of contributing factor in this case. But we keep going and keep going. I think the decision was made at when was it? Delivery was it? Apologies. I think the decision was made at 10:40 to go to. I think I remember this very clearly now. The decision was made at 10:40, so almost an hour after the examination. The decision was made to go to theatre, with the reason being failure to progress. And the fact that we couldn't obviously start anything else based off of the whole clinical picture. So anaesthetic review at 10:50, and at 11:05 she was transferred into theatre. This is her theatre CTG here. Knife to skin at 11:35, knife to uterus at 11:41, and delivery at 11:42. Anybody want to guess the APGARs and the gases?
I feel like the Apgars probably would have been like 9, 10, 10. And I don't know, the gases maybe like, I don't know, 7.2, 7.3, 7.2, I don't know.
I agree
Yeah.
with Rita. Apgas 8, 9, 10. Gas is 7.2, 7.3.
Yeah, perfect. Anybody else?
The last bit has a bit of a sinusoidal trace, to be honest. I would go between 7 and 7.1. So 7.0 and 7.1. So something 7.05 or something.
Yep. Okay, So baby was 4.15 kilos on the 47th centile. Apgars were 9, 10, 10. Arterial pH of 7.1 with a base excess of -2 and a lactate of 4.2, and a venous pH of 7.3, base excess of -1.7 and a lactate of 2.5. This baby compensated incredibly well throughout the entire time the labour was going on for. I think had we started anything like Sinto or anything else, then we would have had a very much a different story. But baby was actually admitted to SCABU from theatre because the baby was unable to maintain oxygen saturations and was kept there on oxygen support for 3 days afterwards. So it just kind of goes to show you as well, you know, gases tell us an awful lot about the story and how baby's been coping. But even when they are sort of on the borderline, that doesn't necessarily mean you've got a well baby. And the fact that this baby's been compensating for such a prolonged period has clearly been sort of shown in the fact that baby was unable to sort of maintain life on the outside and had to require some oxygen support.
How is 4.15 kilo on the 47th centile? So I mean, what was this lady very tall and very high BMI?
No, she had a BMI, I think, of 28. I thought the exact same thing, but according to her gap and grow chart, this was what the centile was. I thought the same thing. Thought that was quite bizarre. I think if we'd have used the what's it called? The WHO one, the WHO gap chart, it would have been a bit of a different story. But on the gap and grow, that's what it said.
I feel like the 90th centile for her will be what, 6 kilo?
Yeah. Oh gosh. 6 kilos, can you imagine? But she had a GTT as well, it was normal. So, and there was no sort of glucosuria or anything like that, so she didn't require any follow-up. But yeah, does anybody have any questions about this? Go on.
You know, we had two lucky incidences that helped us in this case, and thank God, of course, that the propus helped us and fell out on its own. This is number one. And number two is that the baby is big and had reserves to like sustain the hypoxia.
Sorry, Mr. Niggy, can you say that again?
So that we had two lucky incidences in this case. One, the propus helped us and fell out on its own.
Yeah.
And so thanks, propus. And the second one is that the baby is big and had lots of reserve to sustain the hypoxia that we maintaining.
Yeah. It's a tricky one. I think well, as a team on this call, we all were in agreement that we were abnormal from the beginning, and it didn't really get any better. but also the fact that we would have transferred to theatre an awful lot earlier than was done so. But yeah, we've got to take all of the human factors into account and whatnot. But yeah, thank you guys for listening. Does anybody have any questions?
No, thanks, Cara.
Thank you.